Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in.
Hello and welcome to the INS Infusion Room. So we have a very exciting three-part series where Dr. Van Doren is joining us in the podcast studio today to talk about IV iron. And I just want to make mention that this episode for today in part one is sponsored by Pharmacosmos Therapeutics. Dr. Van Doren, welcome to the studio.
Well, thank you for having me on this podcast, Derek. I'm very excited to speak more about intravenous iron.
There's a lot to say. You know, I tell you what, looking back in February, we welcomed you on and you presented a wonderful presentation through our webinar about IV iron. And it had a really great response, great engagement, and many of our members had a lot of questions for you. So we both talked about this offline and decided that we wanted to bring our listeners answers to those questions in that particular webinar within the Q&A chat box. So if you haven't reviewed the webinar, remember it is free for all members of INS. And you can find that back in February. So if you go to the INS Learning Center, the title is Administration and Safety of IV Iron. We'll give you a little bit of a recap. So maybe, Dr. Van Doren, if you want to talk a little bit about yourself, talk about where you currently are within your practice, and maybe a little recap of what we discussed back in February, since it's been a little bit of time.
Sure. So I'm Layla Van Doren. I'm a classical hematologist at Yale, and my area of focus is in iron deficiency and iron deficiency anemia and the diseases that lead to those. And I have another clinical focus, which is sickle cell disease. So people who have too much iron, and then I focus on people that have too little iron. In terms of what I spoke about at the webinar back in February was on the administration and safety of intravenous iron. And I get these questions all the time from around the world and people wanting to develop protocols for their infusion centers and just asking safety questions. And so the first part of the talk was really on intravenous iron administration. Who's appropriate to receive intravenous iron, and how do the different iron formulations differ in their administration and why they differ in their administration. So I thought that was very important. And then focusing on the safety, which was mainly infusion reactions and how to manage those. And then lastly, I believe we did touch on hypophosphatemia as well, which is emerging as a treatment emergent side effect and being more and more recognized.
Well, thank you for that wonderful recap. And we'll just go ahead and jump right in. So we have a lot of questions. We had a lot of questions that day that we transcribed over. So we're going to try to group everything into conversation pieces. But we're going to try to get through as many of those questions within today's segment. And again, this is a three-part series. So you'll want to be able to follow up over the next two episodes that are going to be coming out as well. So one of the key questions, and this came up a few times, is what's the difference between iron deficiency anemia and iron deficiency without anemia? Can you elaborate on that?
Yes, and that is actually a really good question. Because a lot of the times when patients are referred to me, they're already anemic. But I will back up and start by saying that iron is important for many processes in the body, not just red blood cell formation and red blood cell health. It's important for cognitive function. It's important for muscle function. And remember, the heart is a muscle as well, right? It's important for those who are pregnant, for brain development of the fetus. So iron is involved in many processes in the body. And if we lack that, then that's where we can run into potential problems. But it's not recognized because oftentimes, unless somebody is anemic, which is really kind of like the very severe form of iron deficiency, then iron is not checked. So iron deficiency anemia is anemia, right? And then anemia due to iron deficiency, and then iron deficiency without anemia is in the name. You're not anemic, but you're still iron deficient, which can cause a lot of problems.
Where does IV iron come from?
Well, iron is iron, so it's abundant, it's ubiquitous on Earth, and it's basically the same thing as oral iron, except there are some differences. So, iron is toxic to the blood, so it can never be free floating in the blood by itself. It always has to be bound to something. When we ingest iron, it's taken up through the GI tract and it's bound to the carrier molecule transferrin. In terms of intravenous iron, you're having a bunch of iron go into your bloodstream at once. And so it has to be bound to something. So it's bound to a sugar, which is why most of the names for these iron formulations are iron something with a sugar. So like ferric gluconate, ferric carboxymaltose, right? Ferric
Right.
dirysomaltose. It's always a sugar molecule, but it comes from the earth. In terms of
Right.
foods, it's coming from legumes, beans, green leafy vegetables. It comes from meat, but that's a very different type of iron that's absorbed differently than what we think of as iron.
And kiddos with iron deficiency, are there any preferred products?
So I'm not a pediatrician, so I don't know what the pediatricians prefer. However, I will say that wherever there's the most data, that's usually what's pulled off the shelf. A low molecular weight iron dextran has been shown to be safe in pediatrics and some of the other iron formulations, but I don't know that one is actually preferred over the other in terms of pediatrics. Again, I think when it comes, so iron is iron, right? And
Yeah.
really the safety concern with iron will be hypophosphatemia and some infusion reactions depending on the dose that they're given. But when selecting an IV iron formulation, it really comes down to how much iron does the patient actually need and what the insurance company will approve.
And what about the patients with kidney transplants?
So what I will say in general is um, just about any iron formulation will be safe for any population. Usually, we as physicians like to see data in that population. So, there may be data for one iron formulation in a population. And that doesn't mean that other iron formulations are not safe. It just means that there's no data. But again, iron is iron. So I pull whatever's on the shelf. Depending on the patient, I use those intravenous iron formulations.
In regards to patients who are pregnant, there was mention about second trimester recommendations. Can you elaborate a little bit more on that?
Yeah, so we tend to stay away from using intravenous iron in the first trimester, and that's just because there's no safety data for it. We don't know that
Okay.
it's dangerous or harmful to the fetus, but there's just no safety data. So we usually wait until the second trimester to provide intravenous iron to patients. And really, all formulations have been shown to be safe in pregnancy.
Okay, we're going to shift gears a little bit. We're going to go into the runtime and dosing. So we have a handful of questions regarding that.
Okay.
So let's talk about rate. So there was some mention of running iron sucrose at 200 milligram dose. Can you expand on that recommendation?
Yeah, and I think this is actually really important because iron sucrose, also called venifer, the sugar is not bound very tightly to the iron. And so when it goes into the bloodstream, it can disassociate pretty quickly. And like I said previously, free iron in the blood is toxic. And that's why specifically with iron sucrose, it really shouldn't be given above 200 milligrams, because that's when we start to see infusion reactions. I have seen it given above 300. I used to give it at 400 milligrams over 4 hours. And let me tell you that there really were significant infusion reactions. But because of the relationship between the sugar molecule and the iron, it really shouldn't be given above 200 milligrams.
Okay. And then do you have any opinions for giving IV iron push?
At Yale, we do give Venifer IV iron push, and that's the only one that should be given as a push, if
Okay.
it's going to be given as a push, because it's such a low dose. Um, Patients have tolerated it really well. It's given over 8 minutes as an IV push. However, I've also administered it IV infusion as well. And I don't know that the infusion reactions are any less.
And another question we had is really talking about the safety of running IV iron via gravity. And I think I could answer that a little bit from a nursing perspective.
Yes, please, because I actually saw that question and I was like, what?
Yeah, yeah. So, from a nursing perspective, we definitely want to use our resources. So, if we have the pumps available, we most certainly should be using those pumps. As we know, pumps can help regulate. It really increases patient safety and can give real-time monitoring feedback. So, when you're looking at clinical practice and best recommendations, we should always be running our infusions via pump. Would that be safe to say from your perspective?
Well, I actually didn't even know that infusions were run via gravity. I didn't know.
Yes, there's still there, and there are some areas of practice around the world that
Yeah.
don't have available resources. So, there
Like,
still is gravity and having to calculate the drips and go into your drip factors and making sure that your particular tubing and the way that you've calculated your drips is in accordance with the particular medical order. So, I mean, there are going to be those situations. However, we definitely need to be moving towards best practice, and that is definitely using a pump for infusions.
well, thank you, Derek. See, I get education when I come on this podcast. I receive education too.
That's great. That's great. So, okay, so this particular clinician had a question. For a patient that's receiving Remicade and IV iron within the same visit, is there a specific order they should be running those infusions? So, is there one that should come before the other that you know of?
No, so this question actually comes up, and not just specific to Remicade, but any other infusion at the same time
Okay.
as intravenous iron. And there's no evidence to show that whatever said medication needs to be run before or after intravenous iron. So the order or even the duration, how long we have to wait before we give intravenous iron after the other medication. We just don't really have that data. I would say that if whatever the patient receives, whether it's the iron first or the other medication, if they have any kind of reaction, just wait, just give them a moment, give them some time, because anytime there's any medication, they can develop any kind of infusion reaction that's not specific to iron, but any medication.
And that makes it challenging to treat because you don't know which one is giving the reaction.
Yeah.
Is that right?
Yeah,
Yeah.
yeah, exactly. So, in our infusion center, after patients receive intravenous iron, they're usually watched for 30 minutes. That's not any kind of standard of care that the infusion center should go by. It's really just dependent on the level of comfort with the nurses, the culture of the institute. So it's
Mhm.
it's just determined by the individual institutions how long they
Yeah,
want.
and I think that we could guide our clinicians into referring to those organizational policies that are guided by best practice standards and guidelines. So really, it's important to know, and I'll just add this little insert here, that you as a clinician need to understand where you're practicing, what those guidelines are for your particular area, but also your organizational policies and where you stand with being the expert and understanding the standards associated within the. So, what kind of contraindications are there with IV iron and blood transfusions?
Well, there's no specific contraindications to give intravenous iron. What I will say is we usually avoid giving it during acute systemic infections. And I'm speaking of bacterial infections. And the reason is because bacteria love iron. That's how they thrive. Every living thing needs iron. So usually after the infection is under control, meaning the patient has been on antibiotics, symptoms have resolved, if they've have blood culture positive, blood culture is now negative, or if they're on pressors, they're off pressors, and then provide intravenous iron should it be needed. Now, when it comes to blood transfusions, there is iron in a unit of blood, right? Because some of the red blood cells have hemolyzed in that bag.
Yeah.
However, it's not 200 milligrams, and the iron that will be available with the transfusion will be available in several months after the red blood cells have died. And so that iron is
Okay.
not immediately available for during the blood transfusion, and that is why it's relatively safe to give a blood transfusion during an infection if needed. Yeah.
So alternative care settings, are infusions approved in the home setting currently? And are there any special recommendations for the home setting that the clinician should consider?
So I have heard, I haven't done it myself, but I have heard of patients receiving intravenous iron at home. I would say if it's going to be given at home, there should be a nurse there monitoring the infusion because, like with any infusion, there can be an infusion reaction that occurs. But I
Mhm.
have not done it myself.
Okay. As we see care transition into the home, we see more and more of those skilled services being offered in the home setting, really for patient convenience, really bridge gaps in the care spectrum and continuum, and really patients' request to be treated within those environments. So I think as we continue to expand in that, these are great questions that are going to help guide research and practice and really be able to set standards as to what is truly safe versus what's not within those settings. And also, how do we further bridge the gap by allowing additional services and ensuring safety within the care that we provide? So lots of discussions around that right now. And then I'm going to assume the same thing would apply for long-term care facilities. IV iron could be administered within those arenas as long as safety and all the resources were available to safely administer that particular infusion. Correct?
Yes, absolutely.
Great.
If the facility is equipped to provide it, then and has the staffing, then absolutely.
Great. All right. That's all the questions I have for this particular segment. So, our next episode is going to be, is it CARPA or hypersensitivity? I'm excited for this one, Dr. Van Doren, because there was a lot of questions around that particular topic within the webinar. And I think we're going to be able to dive a little deeper and give a different perspective on that to kind of solidify some of the teachings that you went through back in February. So be sure to join us in 2 weeks. So remember that the INS Infusion Room publishes every 2 weeks, every other Tuesday. So be sure to catch that next episode coming in. But with that said, I want to thank you, Dr. Van Doren, for coming into the studio today to give some expert insight of the clinical topic that we discussed today. And I look forward to the next episode. I'm your host, Derek Fox, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.